Oh, okay. I know we have a couple members of the policy roundtable who are still just coming back on camera, but I just want to check to see if we have, let's see, who do we have? I see David Dohan, hello. So I'll introduce you since you're here, but Alysa's here too. Okay, great. And I know Nikki will be joining, I'm sure, back shortly. Okay, so and an hour felt tight, obviously, to do all of those votes. Now we have a hour and a half, but believe me, it's also going to feel tight because we've got a huge terrain to try to cover. And some of the issues we'll actually be talking about could take an entire afternoon meeting all unto themselves. But it's really a kind of a chance to step back and to look forward to the decisions that are going to be made as this evidence gets translated into our quite imperfect healthcare system. And we're going to talk about how we can get it right around everything from, again, the clinical aspects of who's getting it and how patients are plugged into clinicians and how they find out about these treatments, et cetera, to how insurers will manage the coverage policies and how the manufacturers obviously have already priced them, but what lessons we can learn from that going forward. So with us on our policy roundtable, we are very pleased to continue to have our clinical experts, Dr. Scott Kahan, and Dr. Lee Kaplan. And we've got Joe Naglowski and Nikki Massey, our patient experts. And joining us now are two representatives from the payer community, who at least can represent the payer perspective. David, why don't you go ahead and introduce yourself?
Thank you. My name is Dr. David Dohan. I'm the medical director for pharmacy at Point 32 Health, which is a combination of Harvard Pilgrim Health Plan and Tufts Health Plan. We merged about 2 years ago. In addition, I do work part-time at Leahy as a primary care physician.
How many years do you think it's going to be before you have to stop explaining that it's Harvard Pilgrim plus Tufts? How many years?
I say 5 more.
5 more. Yeah, for those of us in New England, it'll be a while. We'll always wonder what the heck. Thank you very much for being with us. And Alyssa Guest, who is not a payer, but works for a company, IPD Analytics, with whom ICER interacts to get really good insights into the pipeline of emerging drugs, but also into the patterns of coverage, the lessons from prior similar situations. So Alyssa, anything else you'd like to tell us about IPD Analytics?
I think you covered it pretty well. We keep a close eye on what the industry is doing as far as payer management is concerned, which just helps to lend some helpful perspective in a forum like this. So thank you for having me. I look forward to the discussion.
Thanks a lot. Okay, we can take down this slide then and hopefully just look at each other. Okay, so the way I have this roughly kind of blocked out is I want to talk a fair amount about getting it right as far as equity across different stakeholders. And then I want to turn to some of the nuts and bolts around how coverage will be structured from the insurer side and the employer side, because here, unlike some other topics, this is going to involve a lot of employer decision-making as well as payer kind of decision-making. And then we'll round out with some considerations around future research opportunities to continue to get good evidence. So I do have to note, though, in this lineup, and actually the chair of the CEPAC raised the question of the representative from Novo Nordisk. I find it not just regrettable, but really not appropriate for a company that is hoping to market its products to the US public and to engage with thought leaders around issues of access and pricing to choose not to participate in a public meeting because of what they call a business decision. So we understand what those feelings might be sometimes, but we think it's really kind of not admissible for a company to decline, and very few do. But those that do, I think, should be identified as not really doing what I would think, and I think what we would think is fair, to be able to come and to have these kinds of conversations, which don't always end up easily. You know, they're not easy, and that's the point. We have to kind of be willing to talk about some of these things to each other in a way that's more public and accountable. Okay, got that off my chest. Let's talk about equity. So as new treatments, these ones we've been talking about, in particular, semaglutide now that it's the newest, as they're introduced into the practice, I kind of want to ask you all, what do we need to think of as recommendations for what all stakeholders can do to reduce those health inequities? So, for instance, I wrote down, unfortunately, the manufacturer's not here to respond, but maybe others can. Because I've come to learn that the patient assistance programs for these treatments really don't match the amounts for other chronic conditions. So that, if you've got rheumatoid arthritis or maybe other kinds of conditions and the drugs are expensive, the company helps out if the insurance coverage, if you're in a deductible plan or something like that, or you don't have any insurance, but it's not quite at the same level for treatments for obesity. Can anybody else speak to that issue? I don't know if the patient community is aware of this as an issue or not, but Joe, you look like you unmuted. Go ahead.
Yeah, I'm happy to jump in here. And I think just fundamentally underlying all of this, and it was implied all day, I just want to state it out front though, is that the vast majority of us living with obesity do not have access to any of these treatments that we talked about today. Probably only about 20% of people have coverage for these services right now. I'm not saying that it isn't growing rapidly, but for the vast majority of us, I've been on multiple of the medications that we talked about today. They've never been covered by my insurance, right? I've had to find the ones that were payable out of pocket. And so this cost issue becomes a significant one. But to your point, Steve, I think the key issue here as we look at this is there are multiple aspects of this, right? Yes, we need insurance coverage, but we also need the manufacturers to step up and actually develop patient assistance programs. And we've, as an organization, have been advocating around that for a while. And we've seen develop some programs, but they're not the traditional ones you see for people of lower socioeconomic status, some of the ones that you mentioned before. So a couple of our manufacturers that we talked about today have a program that will give folks the medicine for under $99, right? At least two of them that we talked about today are available that, but others have chosen not to, and the drug is still $1,000 or more out of pocket if you don't have coverage. So it is worth acknowledging that, we're asking insurance companies to treat obesity like a disease, and we need to then ask our manufacturers to treat obesity like a disease as well and develop these kind of patient assistance programs. It's important, especially when we're talking about these health equity issues.
Okay, thanks. That's very helpful. Does anybody else have a perspective on this that they feel is important to add to the general thinking? I can imagine that a recommendation again being that manufacturers treat their patient assistance for this just as they would any other chronic condition, and they make it commensurate. If anything, because of the preponderant effect on diversity of diverse communities of color, and rural communities, that they might even need to up the patient assistance in some element because the socioeconomic status of these folks is not going to be as high as for other conditions. Nikki, and then Lee, go ahead. Actually, Lee, go ahead. You were first, and then Nikki.
I'm going to defer to Nikki first because I want to hear the patient perspective.
Okay, good. Thanks. Nikki, go ahead.
I was just gonna say, just so far as like the employer assistance angle is, I've had two major surgeries in my life. One being bariatric surgery, the second being cancer treatment, and the two were like worlds apart in how what my employer opted into with our health insurance plan and the availability of assistance. My weight loss surgery came first, but to understand like sort of the disparity there, you have to talk about the cancer surgery first, which was a totally integrated process. There was no red tape. I didn't have to figure out what I qualified for, what I didn't qualify for. The insurance company and me agreed, yes, it is bad that you have cancer and you need treatment. And it was a pretty seamless process. There wasn't like all of this, hand wringing about whether or not I'm gonna have to, get approved and things like that. Whereas with my weight loss surgery, and I know that that's different than a pharmaceutical, but with my weight loss surgery, there was always at every step of the way, not only was the onus on me to keep the process moving forward from the perspective of my my healthcare company, but then also there were times where I ran into things where I had to get like special permissions or things like that because it wasn't necessarily something that my job had opted into in in its larger plan. And so, that's just one example. It was just like very, very hard to navigate that system. I don't know if it's the same with pharmaceuticals, but it was just two completely different experiences there.
That's I'm sorry for everything you've had to go through on multiple levels, but actually the stories of those families and individuals that I mentioned at the very beginning of the meeting, a lot of it does. I mean, some of those stories were in the same kind of gray zone where insurance coverage was maybe not, and it was poorly coordinated, and that's probably why they started to get a lot of bills that they weren't able to pay. So anyway, that's Lee. Go ahead.
Yeah, I think that we're in a situation now where less than 1% of people who have obesity get treatment of any sort, of any major sort, or any significant sort, other than a doctor or another provider saying go lose weight. And I think that when we talk about equity, we always say equity is not the same as equality. And not everybody needs treatment. And I think that one of the things we need to do is we need to, in addition to the prices are way too high, but in addition to that, we need to consider who should get coverage at a higher priority than other people, independent of their ability to pay. Today, the ability to pay and the kind of insurance you have, in fact, it's mostly the ability to pay, determines whether you get these therapies. And that's the least equitable way. But it's perfectly equitable to say we need to prioritize who gets these expensive therapies at the same time we're trying to reduce the costs. I think we should look at that as well. With cancer, we don't treat everybody the same way with cancer because the cancers don't require that treatment. And with obesity, we shouldn't fall back on the easy trope that, well, there are so many people with obesity that the society can't afford this. We should say there are people whose obesity is severe enough that they should be prioritized for treatment, even expensive treatment, and there should be people whose obesity doesn't require that. And if we take that into consideration, I think we do a better job of finding the right equity balance.
I'm glad you mentioned that. That is a great prelude also to the discussion when we get to the coverage criteria for insurers, because your idea of whether we want to target treatment or prioritize treatment in some way on clinical grounds is something that a lot of payers will be thinking about. So we'll come back to that for sure. So let me swing over to employers and payers too, I guess, to a certain extent, because we're also at this really interesting juncture where, well, it's almost like, I forget how many years ago it was, when pharmaceutical coverage was kind of optional, right? People could have health insurance and you would have a rider or something. You could buy pharmaceutical coverage because drugs were really inexpensive and there weren't that many of them. And now you can't imagine, right? I mean, we passed Medicare coverage for drugs in 2003, but you really can't imagine an insurance, being offered without drug coverage to a certain extent. But what about for obesity? So right now it's kind of optional, right? And employers are largely being asked, do you want it as part of your health insurance for your employees or not? So I'm curious about whether you think we're already at the stage where that should be not appropriate, where we should say, no, it should be part of health insurance coverage. It shouldn't be an optional employer add-on, because that increases the stigma. It increases the problems, employers making a decision are going to have to come back to their employees and say, oh, your health insurance premiums are going up next year because we're covering treatments for obesity. I mean, I can imagine different reasons that people might feel that we want to move beyond the add-on or add-in phase. But this is a good question for maybe all of you, including the insurers. Do you think it's too early? Are we really at a phase yet where it's, you're going to need to keep a market differentiated between those employers and other sponsors who really do want to include it, but you need to have an offering that doesn't include it for whatever reason? Maybe start with the insurers on this one. David, are you familiar with this situation with plan sponsors? I know you guys at least have some of your coverage that does include obesity, but I'm not sure if it's for all your third. Go ahead.
All our fully insured members, we cover obesity medications in full. Our self-insured customers often have a different PBM manage their pharmaceutical benefit, and they can choose what they want, and it's not regulated by state regulations because they're self-insured. It's all federal regulations. And I would point out too, and someone did mention it before, the government, both Medicare, Medicaid, still do not consider obesity a medical condition and cover these medications. And it's a real shame. We operate in those markets as well. And it's painful when we have to deny it.
We're going to come back to Medicare in a second and Medicaid too. So what do you think would happen if is the market just not ready for all self-insured employers to be told, no, we're not going to do a benefit design with you that doesn't include obesity treatment. We view that it's discriminatory, or whatever you might say.
I think in the Northeast, the market is there. And we are covering it for everyone. I don't think we allow anyone to opt out. And actually, I haven't seen it on the self-insured market that we have, but I'm sure it's there. But I think in other parts of the country, people still have this stigma and don't consider obesity a medical condition. And I think the medical community has just gone there as well. I mean,
Right.
Our coverage was very different 10 and 15 years ago. And now I think our entire company will say, this is a medical condition, we should treat it as such. But I'm not sure if that was true 5 or 10 years ago.
Thanks. Alyssa, I'm not sure if you do know more about the plan sponsor world in terms of how they are interacting with the payers on this. But I've met plan sponsors who represent unions, retirees, and they barely can scrape up the money to pay a premium for pretty bare bones coverage. Is the market set up so that we can expect as a kind of a policy norm that even they should include treatments for obesity, given the number of patients who might need treatment? And this is both kind of an ethical and a business landscape question. Like, how do you see this playing out? Do you think, like David said, we're heading very rapidly towards one in which all plan sponsors will cover this, or is it going to stay kind of bifurcated as it is today?
Yeah, that's a great question. And I think, the reason why this is still an optional benefit with many insurers is that it's viewed as a cosmetic condition. And so it's grouped in some of those optional benefits. And I think as we progress and view obesity as a true medical condition that requires treatment, I think inevitably insurers will have to change their mindset and start to recognize obesity just as any other condition. And it's a hard pill to swallow because of what you said, that the prevalence is so high. And so when you're looking, you see these $1 million treatments that only have 100 patients in the world, but then you're talking about a $16,000, $17,000 treatment with millions and millions of affected patients. It's a difficult concept for insurers to warm up to, but as that perception of obesity really, starts to move more in the direction of this is a medical condition, what can insurers do? Because at that point, it's no different than anything else, like diabetes, for example.
Well, if we're talking about equity as the first lens through which we're jumping into this, it certainly feels like, again, I painted a picture in which it's the less well-resourced plan sponsor who's trying to, cover their population. And I really, you have to walk a mile in their shoes to understand how hard the trade-offs are that they have to deal with between the benefits they can provide. But it's only going to increase disparities if we let kind of wealthier employers and their workforce get coverage for it. And again, the people who have limited insurance from probably less well-endowed plan sponsors are the ones who don't have coverage for it. It just seems like a recipe for more disparity instead of improving it. Joe, go ahead.
Yeah, so Steve, I think one thing I want to think about, we talk about this worry of overutilization, right? That everyone's going to run out and use obesity therapies. But that's actually never happened when it comes to obesity care, right? It wasn't long ago that we were having to convince employers to cover bariatric surgery, and everyone said, well, so many people are going to have bariatric surgery, less than 1% of people who are eligible have bariatric surgery. If we actually look at obesity care right now, less than 10% of people with obesity actually ever see a healthcare provider to get counseling or any kind of form of treatment for their weight, and only 4% of them see a prescriber, right? So we're talking these are not as nearly as big numbers as we think. So I sometimes challenge this concept that, yes, I know there are 100 million people eligible. And I think Dr. Kaplan did a good job saying, wait a second, we're not going to treat all 100 million of those folks. It's actually a much smaller population. And I think we have to be more consistent in our messaging around that. Now, our challenge becomes, it's a chicken and egg argument, right? We have to create the coverage to know what the utilization is going to look like, right? And we can't figure out the utilization until we know the coverage. And so we're caught up, I think, for the last number of years around this issue. We've made it so that people have to earn obesity care, right? That we make patients jump through all kinds of hoops to earn it. Instead of saying, wait a second, this is one of the greatest epidemics we've had as a world and as a nation. We should be encouraging people to have obesity, to seek obesity care. And it's because of that balance, because people are so worried that we're going to overwhelm the system. But the evidence isn't in place for that. Again, and bariatric surgery is the example of that. So.
You're right. And I think we are maybe at a point where there hopefully will be enough evidence soon on the uptake, as you said, to help, because each employer looks at this. They don't care if it's 40 million Americans, none of that. They're going to listen to an actuary or a health benefit consultant say, if you cover, your premium's going to go up by X, and they have a formula for doing that. So I think it is important, though, to hope that the real world experience with use can inform that kind of actuarial prospectus, and it might help ease the path towards broader access. I agree. So teach the world here about Medicare and Medicaid. There's a Treat and Reduce Obesity Act. I'm not sure where it stands in the halls of Congress right now, but as somebody mentioned, Medicare does not cover it because it's not viewed as a medical, I forget the exact terminology, but it's somehow outside the strict statutory benefit provided by Medicare and Medicaid too, if I'm not mistaken. But what's the best way forward? What's the best recommendation we could make to address equity through consideration of government action around these issues? Joe?
Steve, since I spent the last 10 years working on the Treat and Reduce Obesity Act, so I'm happy to talk to you about it. So first of all, just to clarify here, so the Treat and Reduce Obesity Act would do two things under Medicare. First, it would improve who can counsel for obesity. So the providers, it would allow dietitians to do it. It would allow specialists to do it. Right now, you're only allowed to be seen by your primary care provider to be counseled under Medicare for your body weight, right, for obesity. The second thing it would do is eliminate the prohibition under Medicare that currently states that agents for weight loss, weight gain, or anorexia are excluded. This is actually old language from an old Medicaid bill years and years ago that got worked into Medicare Part D when they passed that in the early 2000s. And so we've lived with that prohibition for quite a while. And so this bill is now in front of Congress. This is now its a sixth Congress that it's been through. We're coming up now, if it doesn't pass before year end, that it'll have to be reintroduced next year. It's pretty widely bipartisan supported. We have, I think, 22 co-sponsors in the Senate, more Republicans supporting it than Democrats. And then the House, I think 151 supporters in the House, more Democrats than Republicans. So it's a very bipartisan bill. But it's been a long slog. And of course, there's a lot of hope here at year end as Congress has to do some real business to fix some healthcare issues that we should be able, or we may be able to get the Treat and Reduce Obesity Act included. Our key issue around this is how much it's going to cost, right? The same discussion we're having today. And in fact, I suspect your report will influence the Congressional Budget Office, who we are hoping is going to score the Treat and Reduce Obesity Act in the next couple of weeks. And so we'll know what the cost of that will be. But obviously, not much of this part of the conversation today will come down to dollars and cents.
Yeah. Okay, fascinating. Thank you. Lee, go ahead.
Just want to make 2 points. One, in response to your question, everything that Joe just said is correct, but the states have the ability for Medicaid to override that. So Medicaid is in a different situation where the individual states can make decisions about how they run their own Medicaid programs, which allows for Medicaid essentially to be what it was partly what it was intended to be in the first place, which is a laboratory for different approaches that then could be generalized if they're successful. So I just would emphasize that, because somebody said that Medicaid also has the same prohibition. It's not true.
Yeah.
There are at least 15 states, at least 15 states under Medicaid that cover obesity medications.
15 now, okay. So again, there's at least some track record there if they're covering it already in terms of what the financial impact would be, which is good. Lee, sorry, go ahead.
And then the second point I would make is that under no circumstances are we going to go just because of stigma, because of attitude, because of, even if we were tomorrow morning to say that obesity medications are covered, just as Joe said, we don't see everybody running to get surgery, and we're not going to see everybody. We'll have more people running to get drugs, but not everybody. And we're dealing in the situation right now where the medications are the most expensive that they're likely to ever be, because of negotiation, because of considerations like the ones we've had today, but also because of the patent law. There are very few obesity medications that are not under patent at this point. That are under serious consideration. Really, the only one that we're talking about seriously today is the combination of phentermine and topiramate. And so as these drugs go off patent, and liraglutide is going to go off patent at least one dose next year, and so that's going to be something. In other disease states, you introduce new expensive therapies on the background of a lot of less expensive therapies, and so we can use the logical development or decrease in cost that occurs from the patent law, plus the decrease in cost that can be negotiated, to again start with the patients who have the most expense in terms of their obesity, and then work our way down. If we just did it from a purely financial perspective, there are people where treating obesity is likely to save money, not cost money. And finding those people and assessing, through Medicaid or whatever, but finding out how we could figure out to the prioritization that I talked about earlier, based on some very objective criteria, would get us through the next phase. And as the years go by, I'm talking about 5 to 8 years probably before these things really take hold. You could then see the natural growth of effective and equitable therapy.
That's great. Well said. Before we pivot to talk about specific elements of coverage policy, I would love to figure out how to frame the knowledge of this group around stigma and bias in a way that sounds like more than just we should avoid it. Who would take, is it the clinicians, is it specialty societies that would deal with this in terms of doctors' approach to people with obesity? Is it the government? Who steps in to help us push forward if the goal is to reduce stigma and bias? You guys have thought about this a lot, and it's probably all of the above, right? It's like everybody has a role to play. But what do you think is the most important next step here to help with stigma and bias in this area?
I think a lot of this has to do with education of healthcare providers. And this is a lot of work that I know Dr. Khan and Dr. Kaplan and Nikki and others have already engaged in, right? They participate in actually training about what obesity really is and really understanding the complexity of it. And then once you understand the complexity of it, you're less likely to engage in that bias and stigma. And I will say most bias and stigma can be very subtle, and it can be unintentional. I don't think healthcare providers are intentionally cruel to people with obesity. I think they've lacked the training to be able to move forward. Now, with that being said, there are going to have to be other bigger solutions as well that actually look at how do we influence the media and the public and some of these other attitudes. But I think it has to start at home with the healthcare community to get them to better understand these issues.
Okay, good. Lee, go ahead.
Just adding to what Joe has said in the same vein, most people think obesity is a disease primarily because it causes other diseases.
Right.
But not wearing seatbelts causes other problems, but that doesn't make that a disease. And so in the same vein, people think that obesity is a lifestyle choice that should be considered a disease because it causes other diseases. in fact, the biology is increasingly clear that obesity results from by itself, with no complications, results from a disruption of normal metabolic physiology. And that's the kind of education that healthcare providers need to know. We shouldn't be saying that we should stop stigma and bias because we want to be nice to people. We should stop stigma and bias because we should recognize that they didn't bring it upon themselves. Short-term weight loss is relatively easy. Long-term weight loss from simply behavioral change is exceedingly hard. And the failure over the last 50 years to be able to change the slope of the curve with lifestyle-based therapies has to be taken into consideration as part of the basis for the biology. And the biology is really where we need to start.
Okay, that's well said. Scott, I haven't given you a chance to jump in, partly because you're in a different quadrant of my Zoom field than everybody else for some reason. But feel free, please, to interrupt, or if you have anything to add now, please feel free to jump in.
The only thing I'll add to that, I agree with everything that was just said. To Lee's last point, I certainly agree that the importance of addressing weight stigma is not that we should all be nicer to people, although that's nice. But I believe it's more than just the point that it is really challenging and they didn't bring it on themselves. Additionally, there's very good studies, and a range of them, showing that weight stigma itself causes harm, physical, emotional, as well as makes it harder for people to manage their weight going forward. So for what that's worth.
Right. Okay, I want to start to pivot towards coverage, but I want you to feel free also at some point, if we have time at the end, we may back up again and talk more philosophically about this. But, you know, part of my job in these roundtables is to make people slightly uncomfortable. And if I were going to try to do that now, it would be to say, what if somebody, you know, the voice that we're not hearing is we're medicalizing something that's now 50% of our population, and it's the wrong track to be on. We should be pouring all of these resources into primary prevention of obesity and not thinking that we should just create a simple pill to take after you've become obese. And I don't want you to answer that now, but as it frames some of the decisions that are being made overseas and that I'm sure some employers are still making, we may circle back to that kind of concern. So before we even head into US coverage, you know, we looked at how other countries have looked at the evidence and what kinds of approaches they're taking to broader aspects of treating obesity. And I'll focus on England and Canada, and just to seek your input. So in England, you know, they have a very sophisticated approach. They look at evidence, they talk to clinical experts, they have patient engagement. And what they came out for just in June, for their national guideline, is that they will cover, you know, these treatments for a maximum of 2 years if the patient is a BMI of 35 and above and has at least one comorbidity. So they've taken, if you will, the population and kind of made it more severely in the way that you were kind of alluding to. Now, you may view this as a very blunt way to do it, but I'd be interested in whether you guys think that that is in any way consistent with the evidence on effectiveness and value. Because we've talked about it, looks like the evidence suggests that it's effective even if you're at lesser degrees of being overweight, but clearly the relative benefit might be greater if you are more overweight. But what's your reaction to a country with that guideline? Do you think it seems reasonable or completely unreasonable? Lee, go ahead.
So I think that is consistent with what I was saying earlier, but that is not, and regulations and legislation are always the crudest way of there's no nuance to them. And so, but this is even worse than that, in the sense that BMI not a good measure of the true costs, the personal costs, the financial costs, all of the costs of obesity. And so I think for today, it's a perfectly fine interim solution. But what we really need is we need markers, better markers of what the severity of obesity is in a person, not in a population, because the coverage is going to be person to person, not in a population. And I think that BMI has been great as a population epidemiological tool, but it's not as good as a decision-making tool for patients. And so while we do that, and I would endorse something like that for the moment, but to do that without simultaneously using all of our big data that we have to figure out who costs the most, what complications cost the most, what subsets of populations cost the most, who's most adversely affected by it. That's how we get to equity. Equity is to say, no matter where you come from in society, if you have the kind of obesity that is having the worst effects, you go first in line. And I think that's really where we need to figure that out using the data that we have. And we do have a lot of data out there, but we haven't done that yet. We've been wringing our hands about BMI, but we haven't actually done the work to go to the next step. And so I like the general idea, but specifically resting, which NICE is doing in the UK. It's right now, it hasn't put into place something that will take it beyond BMI.
All right. And to be fair, I oversimplified their own guidance because they do say that if you're between 30 to 35, you're also covered if you meet the criteria they have for referral to a specialist weight clinic, which is a whole nother set of, so they do get into the weeds more. So they're not just a blunt 35 on off switch, if you will. But, and again, they do these kinds of things knowing the price and trying to figure out, sometimes if the price is X and they can't get it lower, they will say, okay, then it's for fewer patients. But if you lowered the price, they might have lowered that BMI down further. Here in the US, we tend to take the FDA label and sometimes use the clinical trial data to narrow it, but we very, very rarely do it on a basis of cost effectiveness to narrow the population that would be treated. Let me mention one other country, and then if there are any other comments on this before we turn to the US kind of payer world. But interestingly, in August of 2022, so even more recently, the Canadian review agency, they issued a draft recommendation, it's still draft, to not cover it at all, because they said there was no evidence that it had positive impact on cardiovascular outcomes. And they said, until we have that, and I guess they know that the SELECT trial is in the field, until we have that, we're going to say no. So again, an interesting international example of differences in approaches here. Any comments on any more of this before we turn to what American insurers are going to do?
Steve, just on the equity front, I'll just add, because it was mentioned before, and Lee talked about the limitations of BMI, but keep in mind, as mentioned earlier, BMI alone, if you're of Asian descent, right, this measure, you're being excluded from that treatment, even though you may need that treatment at a much earlier or lower body weight. So just something to keep in mind as we look forward here. Again, I recognize that we don't have the perfect system. We're looking for an easy measure, like here's the perfect number, and then this is what you have it. But obesity is much more complex than that. And it really is going to have to be on some form of personalized medicine that takes in health risk into consideration.
All right. I love that you said that, because that's part of the tension that we're now going to talk about. Because when you say that to a clinician, they nod their head, and you say that to a patient, they nod their head. When you say that to someone who has to design a computer system to handle thousands of requests for a product, they have to be able to put it into language that's consistent and reliable and can be administered relatively pain-free. And so that personalized aspect gets harder unless you're just going to give the keys to the car to the clinician and say, you decide. It's covered for anybody who's overweight over the age of 18, and you get to decide. And no insurer is going to do that for a relatively expensive treatment like this. So let's talk about how insurance coverage is going to be structured. So when you look at the paper—
Steve, could I just say something on that score, because I think this has not been discussed. But first of all, the Canada guidelines, the proposed Canada guidelines, basically negate the idea that obesity is a disease. It's only a disease if it affects heart disease, and it negates the other 199 other diseases that Joe was referring to. But with respect to the issue of having a simple criterion and an objective criterion, there are examples that we could follow in this field, and this is our responsibility in the field. You are ranked for whether you get a solid organ transplant using UNOS criteria, get a single number. There are lots of single numbers that are calculated from complex data sets. And I think if we had a single number severity score that took into account the various types of inputs to severity that we could consider, that single number would be very valuable and measurable and calculable for both the provider and for the insurance company.
All right. Well, I'm looking forward to hearing the insurer perspective folks commenting on that idea, because I think that obviously would be something that could potentially be of interest. So in the way that if you read the policies that are available publicly and the ones that will be created going forward, they'll start with a kind of patient eligibility criteria. And again, as I mentioned, they'll either just borrow directly from the FDA label, or sometimes they will use the clinical trial eligibility criteria to be more precise or narrow in some way. So what we're seeing now is just what you would expect. It's greater than or equal to 30 or greater than or equal to 27 with one weight-related comorbid condition. That was the trial, that's the label. So my first question for the payers is that just going to be a hard stop, basically? If someone's 29 and a clinician says, but they've got personal reasons for which this is really the right time and the right window and the right patient, they can always file an exception. But what's the basis for the decision going to be inside an insurer to say, yes, if you've got this BMI of 30 is such a clear line in the sand? David, how do you think it's going to be managed?
So, I mean, mostly I would say it's a hard stop. We do have an appeal process, and I think like one example, and we've struggled with BMI because we realize there's bias in that number, but you need something, and that's the best we have. It's kind of like GFR. I mean, at some point, until something better comes along. But for an appeal, someone might appeal and say, I'm of Asian descent. My BMI is therefore artificially low, and I could see approving that person on appeal.
All right, but you can probably assume that there's going to be a lot of variability in that, right? Variability, even within one health plan. You try not to have that happen, but it's possible that different people on different days of the week might take different things into consideration. Alyssa, are you familiar with anything in this domain of how plans are handling the exception side around BMI and weight loss treatments?
Yeah, absolutely. And really just mirroring Dr. Dohan's sentiment, there has to be some line that defines, what will be approved and not, just from, an inter-rater reliability standpoint, consistency of the rendered decision on the prior authorization. You kind of have to have these cutoffs. And so it's difficult for a payer to weigh that, at least until it gets escalated to an appeal. And in which case, as you said, there's a lot of variability on what the decision may be at that point. But there does kind of have to be some defined cutoff in order for there to be, consistent outcomes from the payer in terms of prior authorization decisions.
So maybe we could say that best practice, at least in one way, would be to have internal people managing exceptions be completely aware and educated on the racial and other differences in BMI that might play into an exception decision, instead of just letting that kind of happen ad hoc. It seems like there could be a role for payers to make sure that their staff are fully up to speed with that.
So one thing I would add is, we do have an appeals committee, which is a standing committee. So people are educated and there's more interreliability there. Unfortunately, for expedited appeals, which a provider can say anything's expedited, or honestly, if it's medically necessary, there we see more variability. We do training try to decrease that variability. But on our appeals committee level, which the weight loss drugs would go to, we do have a fairly consistent approach with the
Okay.
same folks there.
Okay, good.
You know, I would just add with an appeal, a lot of that responsibility is on the provider who is submitting the information, the appeal and the case that they make. And, you know, of course, the appeals committee is going to have a baseline level of knowledge, but if there's certain points of consideration that are specific to that patient that they think make a compelling case, unfortunately, the responsibility does somewhat go on to that provider.
Two other parts of the kind of trial eligibility and the FDA label that I think could create some questions. One is age. Usually age is something that is not argued about that much, but in this case, you know, there are a lot of adolescents with obesity. And I'm just wondering, either from the clinical experts or the payers, is age 18 years or older, you know, is that another one of those lines in the sand, and would it be hard to imagine an exception to that, or is it going to be a case-by-case situation for 16 and 17-year-olds? First, clinical experts, do you guys see 16 and 17-year-olds for whom it would be okay to wait? I mean, what's your sense of the 18-year-old line in the sand? Lee or Scott?
So I can say that, so first of all, three of these medications have been approved in adolescents. So Qsymia is approved in adolescents now. Liraglutide is approved in adolescents. We didn't talk about orlistat, but that's approved in adolescents. And then phentermine, old school generic phentermine, is approved down to, I believe, an age of 16, for what that's worth. Look, I can say clinically, as an adult doctor, I'm not a pediatrician, I'm not an adolescent medicine doctor. I see a few older adolescents, and on a case-by-case basis, I do occasionally use medications in older adolescents. Again, at this point, it turns out that now they're approved, but go back a couple of years and you know, I did carefully use them in older adolescents even before those approvals. So
yeah, I guess I was thinking more of semaglutide. You're right, because that's the one that's age 18 or over. So
but that's only now. That's only now. That is going to change.
right, you think that'll change pretty quickly? Okay, so again, something insurers may want to know is that if history is a record here, that we're on track towards it being approved for younger patients before too long. The other one that I can just imagine creating.
Steve, could I just comment just briefly about this bright line at age 18?
Yes, please.
Beyond just what's available. Just a story that when we set up our center back in 2000, the psychologists in our center were very concerned about using bariatric surgery, because at the time there was a concern that bariatric surgery could exacerbate eating disorders and other kinds of psychological problems. And the world has changed since then. But the reason I'm telling that story is because when we opened up our pediatric center, which was only a couple of years later, the psychologists in the pediatric, which is basically adolescent group, were the strongest proponents for bariatric surgery. And they made the argument, which I'll now make, that if you have severe obesity and you're an adolescent, and the effect that has on your education, on your social development, and on your ability to function in life is so devastating that it is essentially it poses a high risk to life, not just a high risk to health. And so just by extension of that, to arbitrarily say when a drug is approved or a therapy is approved in children or adolescents, to say we're going to have a bright line cut off at age 18 does not seem appropriate.
I think health plans are a little bit burdened, as in some way that doctors are too. If they create a formal policy to approve off-label use.
No. I'm talking about on-label.
Oh, on-label. Okay. Sorry.
I'm not saying change the label. I'm saying though, these are drugs that are on label, 3 of them as
Now, right, as Scott said.
Yeah.
Okay, got it. Okay. Another issue that I see being a real sticking point or question too for insurers is, patients in the trials, I believe they'd had already had attempted and failed the patient. This is bad words from my part. Let's say that they had been on a formalized weight loss program and it did not work for them. That is now part of the coverage for at least one major payer in the country, is that an individual has to have attempted to lose weight through a formalized weight management program for at least 6 months prior to request for the drug therapy. And then when they get the drug therapy, they have to be currently on a reduced calorie diet or exercise program. So it's woven into the coverage for the drug that they have to have tried and not had adequate success with a prior program and be on a formal calorie diet exercise program. Insurers, and Alyssa, let me turn to you first. Is that likely? Actually, I can see Harvard Pilgrim's policy right in front of me here, David, just so you know. and I was not, and that's not a part of your coverage. It's part of a different, a national plan's coverage. But Alyssa, because you have maybe a broader perspective on all the different variations out there, what's your sense of how common that is for the plans to be requiring either former use that didn't work or current use of these programs?
Yeah, well, I will say the second part of what you mentioned, that the drug will be used as an adjunct to reduce calorie diet and increase physical activity, that's part of the label. So I would say that is probably far more universal in payer management than the first of what you mentioned. But certainly requiring a previous attempt at weight loss is not unreasonable, and in a way, kind of like you could think of like a step therapy requirement. You want to ensure that the patient has tried this before. But I would say that in terms of outside of the label criteria that we see, that is one of the more common requiring that previous trial. And I think, I don't have all the inclusion criteria pulled up in front of me, but the verbiage changes slightly from drug to drug and trial to trial. I think for Wegovy or semaglutide off the top of my head, it was more informal, kind of just the patient had a self-reported attempt at weight loss. And so, sometimes it's not as formal as what you detailed, and you'll see payers kind of taking varying approaches there to how much they require the patient to have tried in the past, whether that's a set duration, like you've tried for 6 months or, whatever that may be. We kind of see a spectrum there, but definitely more common.
So let me push the envelope there too, to maybe be a little bit provocative. I think that's nonsense. Let's assume that there are some people out there who say that's just a way for payers to protect themselves from being the easiest one in the neighborhood to get coverage on. So they have to be just as, stringent. And it's natural to put in the FDA label language and all that. But there's even data that the drug works just as well in people who don't do any kind of formalized program. I've seen the manufacturer on a platform at a conference with a payer saying the good thing about semaglutide is you don't have to make your patient try a useless weight loss program that almost works for nobody anyway. And so that's what makes it so great. So part of me wishes, well, let me just open it up there, because I think there's a natural tension. It's in the FDA label in some way. It is also a competitive market in which if payers are much easier to get coverage for a certain drug than their competitors, that can be held against them or work to their financial detriment. But it seems like there could be an argument made here to ditch these requirements for dietary weight loss programs, either pre or during the use of these drugs. I want to hear from several people on this. Joe, go ahead.
So I think a lot of these rules are leftover rules from bariatric surgery, right? We've actually typically, again, these worries about people overutilizing care, they've based this, and I think a lot of them, honestly, especially the one requiring a 6-month, weight loss program or diet prior to the time, is based in bias, right? The simple reality is there's an assumption that people with obesity have never tried to lose the weight, and that is a false assumption. Okay, every single one of us who struggles with our weight has tried our entire lives to lose the weight and to address these issues. So this idea that an insurance company would make me again earn coverage by going through another 6-month diet program when I've spent my entire life going through these programs, to me, that's based in bias. And so, Steve, I think I take your combative view around this, that it's not the right thing. It's not because of the mechanism of the drug. I'll let Lee and others talk about that. It is simply that this concept is based in bias, that we're assuming people haven't tried hard enough. And that's a false assumption.
Okay, thank you, Lee.
So first, I was going to say the same thing about bariatric surgery, so it's already been said. Second thing is that it's based in bias. That's already been said. But I think that it's our responsibility as professionals to help define some of these things. And I've said that in different ways already in this discussion, but I want to reemphasize it, because if you look at the label for several cardiac drugs, several lipid drugs, several hypertension drugs, and several of the diabetes drugs, they are labeled as an adjunct to lifestyle. But in all of those cases, the professional societies, the American Heart Association, American College of Cardiology, the American Diabetes Association, all those societies have said that their guidelines, their recommended guidelines and standards of care do not exactly follow the label that's put on by the FDA. The FDA label is to determine what the drug company that makes the drug is allowed to market based on. But the medical community is perfectly able, permitted, and does change that in terms of the guidelines for best therapy. And I think that it's our responsibility in the obesity community to do the same thing, and we should be encouraged more forcefully to do that. We help to extend the stigma by being defensive about the use, because we say, yes, it's a disease, but we recognize that a lot of people don't understand or believe that, and so therefore we get defensive. We shouldn't be defensive. We should be like the rest of the medical community.
Okay, thanks. David?
So interesting enough, we just had this discussion at Point 32 Health as we were looking towards next year. Right now we require, dietary behavior modification and exercise program, but we don't really define it that well. We say Weight Watchers, but we don't say you have to do Weight Watchers. And I'm actually kind of curious from the experts here, what is that appropriate? We kind of feel, and I think there's some worry as these get going from weight loss centers to average PCP, OBGYNs prescribing it, that who are rushed on time, that people are just going to give the medicine without much education, discussion, versus a weight loss center, which they're doing a lot of that already. Kind of that clearly you need motivated patients. And what's that line? I don't have a great answer to that. I do think weight loss and dietary thing should be somewhat there, but I don't think it can be a formal, you need to do X, Y, Z program, more just the patient is motivated to do it, which I think the vast majority of patients really are. I think at this point of who's getting it, you almost have to be very motivated. I'm not sure over time if that might change a little bit more. And we saw the same thing with Chantix.
And I'll just add on that as a former primary care doctor, I do feel that this might be an interesting transition as it moves from patients seeking treatment, having been very motivated throughout their lives, as you said, Joe, et cetera, to a primary care doctor seeing a patient who's never asked a question about their weight. You're not even sure whether they know that being overweight is a medical concern for them. And your choice is whether to bring it up. And do you bring it up as part of counseling around the whole aspect of lifestyle modification, or you just say, I've got a new pill or injection for you to help you lose weight? So that it is an interesting question of whether, as David said, they're trying to figure out how to hardwire some broader education into a situation in which it may be that patients haven't had that kind of chat with anybody.
Steve, I think I'd find it rare that a provider would just offer a medicine without first having some conversation about the person's behavioral lifestyle and health issues around their obesity, right? I think, again, I worry that, I understand where you're going, because most now people who are prescribing these are specialists and they have these comprehensive programs. I would love to have gone to Dr. Kaplan's program or Dr. Kahan's program and the kind of care you can get there. But I think most providers are not writing these willy-nilly, right? In fact, the prescription rate for these medications is very, very low, right? And it's usually, again, written by a provider who's done some extra education and understands the value of behavior management as well, and has resources. For example, if they see the patient is specifically struggling with a specific aspect of their behavior, can refer to that, while also combining these medications. Because the reality is, and simply put, if my problem was over consuming, when I was on the medications, I would need a full sandwich. I would eat 2/3 of my sandwich, right? And it was an unconscious decision, not a conscious one to do that, right? Kind of thing. And so that's just the aspect for how many of these medications work for people.
David?
Yeah, I guess I am a little concerned about this, Joe. When fen came out, we had tons of patients. And I remember, because I started practicing at the very tail end, then all the discussions of people who were on the medicine for cardiac risk review. And people said, my doc just gave it to me, that they hadn't had that conversation. And I think even primary care is even more rushed today with more things to review. So I do have a concern for that.
Yeah. And we may
I think
be
it is worth acknowledging. Yeah, acknowledging the fen example. I mean, it was a challenging example, and fen became a trend, or I don't know what you want to call it, like a cult following, right, kind of thing, and it moved forward. And heck, a quarter of the people who were on fen had a BMI of less than 25, so not even the population we're talking about here, right, kind of thing. And so I think it worth acknowledging that was different times, and I think culture has changed around obesity. Now, obesity medicines are serious medications for a serious problem. We actually don't have, at least that I can see, and even engaging with our friends at FDA and NIH and others around this, we don't have this misuse of obesity medications, right? The people who are eligible for these medications are using them. We don't see this abuse of medications that you could have argued, happened those decades ago. So.
All right. Well, I think we're at a fascinating point in time, especially just before maybe the first oral option of a GLP-1 becomes available, and that might be another tipping point. I have about 10 to 15 more minutes before I want to let you guys make some final comments. And I have several really important areas, so I'm going to be a little bit more kind of brusque and go through a couple just to get some rapid fire thoughts out here. Because there's some other important aspects of coverage. It was already mentioned before about combination therapy. That clinicians view that's kind of what they've been doing all along with the existing options to some extent when necessary or helpful. So I think, Lee, you were the one who said you were, clearly going to, for the right patient, you would be using the GLP-1s along with other things. Payers, or Alyssa and David, do you think that at least initially that's going to be constrained by healthcare coverage? Are they going to try to say semaglutide alone, you can't use others at the same time?
I think you'll certainly see restrictions as far as, concurrent Saxenda and Wegovy, just given the similarities in the mechanism of action. But outside of that, I do think that there would be some, at least as far as what we can see in policies today, some leniency as far as combination therapy is concerned, as long as the provider feels there's a clinical rationale.
Okay, good.
I'll say that's a common situation. So if I'm filling out a prior authorization form for a medication, most frequently there will be a question asking, are they going to use the medication with another obesity medication? Now, I don't know if that necessarily will disqualify the coverage for that, but that is frequently asked in prior authorization requests.
Okay, I'm going to keep going fast. The next one is step therapy. We talked about combination therapy. But as the options increase, I just want to paint a picture in which, let's say an employer or a health plan hasn't covered obesity treatment before, and now they're going to, and they're staring at an option like phentermine topiramate, which is much less expensive than the GLP-1s and somewhat less effective. They could say, well, this is just like statins versus the PCSK9 injectables. I'm going to start with the oral one that's might work for a number of people and get them to where they need to be below 30. And for those who don't get to where they need to be, then we could go with the more expensive option. Is that going to be a line of thought that you think, Alyssa, let me start with you. Do you think a large number of payers or employers behind them will be taking that line, or will they not go that direction?
As far as what we see today, step therapy is not a very common management approach. Certainly, I've seen many payers that, I was just say some payers that do require specifically like over-the-counter orlistat before access to the injectables. And obviously it's due to the significant price discrepancy, but definitely more uncommon. I think there's just question as to the value there, especially with phentermine topiramate and orlistat for that matter. You know, I think there's uncertain value there in implementing the step therapy, maybe just delaying the inevitable, and they could start on the more efficacious semaglutide to begin with. And I think we're also seeing payers manage some of these intricacies through their formulary decisions. When you're looking at formularies, I have seen many that exclude all others except for semaglutide. And, you know, obviously I'm sure rebates play into that, but I think largely the efficacy may as well. Just a more selective decision as to which they provide coverage for.
David, how did this come down for you guys? Did you even blanket step therapy? What happened?
I think at one point, a number of years ago, we had step therapy. We removed it. We actually prefer Wegovy, semaglutide, over liraglutide because it's more effective. You know, I do see it coming back when liraglutide goes generic and there becomes a big price differential. You know, I could see it, but I think the GLP-1s are so much more effective in safety data that.
Right. Well, we haven't even talked about tirzepatide. Obviously, it's on the horizon as well. So there may be a new form of competition among the brands while liraglutide goes off patent. So there are going to be all kinds of new competitive issues. And as Alyssa mentioned, step therapy is not the only option here. One would be to get the best discount on Wegovy. I know this happens. The companies can ask the payer to exclude everything else to get that bottom price from me, because that means that I get all of the market from you. And so clinicians might find suddenly that they have no coverage for patients except for Wegovy or something like that, or tirzepatide. If those two go head to head, we're likely to see some very diverse and interesting market reactions, including just going with one and excluding everything else from the formulary, like Alyssa said. Lee, go ahead.
So yeah, I mean, I think we can't predict all of what's going to happen, and there are at least a dozen other drugs in the same categories that are in development, and so as these things play out, we're going to see a lot more of this. The idea of tiering, of course, has been around for a long time, and so you don't have to do step therapy. You could just do tiering criteria. And the other thing is that we haven't talked about is efficacy. In a given patient, there's such a variability of efficacy that you could require efficacy in order to maintain therapy over a period of time. And so there are a lot of different potential solutions that could be put into place, and I think all of them have to be considered.
Right. The clinical experts, real quickly, let's assume for whatever, just for hypothetical purposes, a payer wants to do step therapy, says, look, I know the evidence suggests that Wegovy is the best in terms of % weight loss, but, you know, they don't have cardiovascular outcomes yet. And as you said, there's a lot of heterogeneity. So I'm going to require patients to try phentermine topiramate first. And if that doesn't get them to target in 6 months, then they can have coverage for Wegovy. How clinically appropriate or inappropriate would it be to pick one first step option Or could the payer say they can pick any of the available bupropion, naltrexone, or phentermate, anything except the GLP-1s, and give those a try for 6 months, whichever one they want. And then if that doesn't work, they can get Wegovy. Does that, would that seem completely clinically insane?
It would be insane if there weren't an out for contraindications.
Of
So
course.
you have to have an out for contraindication, medical contraindications. But that's exactly what we do today. And I think that when liraglutide goes generic, you see, you now do have a GLP-1, not nearly as good as the other GLP-1, but you have all the choices. And there are patients who lose 20% of their weight on liraglutide. It's not a lot, but there are some. And so that at least helps guide the clinician as to a way of approaching it. Again, if it doesn't work for that individual patient, so they get delayed by a few months before 6 months, whatever the number is. But at that point, though, you do have the out that then Wegovy or tirzepatide or whatever becomes available to that patient. I think that is not a crazy idea, but you have to make sure that it has medical sense to it, which is there are people with tachycardia, for example, that should absolutely not be on phentermine, and there has to be an out for that.
All right. Thank you. Scott, do you want to add anything to that? I know it's
No, I
touchy
think
stuff.
that's fine. I agree.
Okay. I'm going to keep going fast. I bet each of you would like to talk about that. Two other quick things: provider qualifications and duration of coverage. And then I'm going to state what I think is another one that's just, I think, a consensus. Provider qualifications. I'm not that familiar with whether a lot of the health plans have only allowed prescribing by specialists and weight loss centers, et cetera. Semaglutide, are there going to be provider restrictions? Are a lot of plans going to still narrow the universe of providers who can prescribe it? Or if we're talking about equity and access, should this be a primary care nurse practitioner level decision at this point? Alyssa, what do you think the plans are teeing up to do? You've already looked at what a lot of the current coverage is. So what do you see?
Yeah, agree with your take on the current coverage. It's not very common to see a specialist requirement for these therapies, and I see it continuing that way, certainly from an equity perspective. Requiring a specialist prescription of a weight loss therapy is really inaccessible for a lot of patients. And so I think we'll continue to see no restriction as far as prescriber type is concerned.
Okay. David, any difference on that from your
No difference, although I think most of the prescriptions we're seeing, or at least a large majority, are still coming from specialists, but we don't have any restrictions.
All right. Just wait for the PO version. I'm sure it's coming. All right, good. Thank you. That helped. Now, duration of coverage is a part of every formal policy. And I'm not sure there'll be that much debate about this, but they are set up differently. Some of them are set up to say that if you lose 5%, you get to keep taking it, and you get 6 weeks, or not 6 weeks, like 6 months, I think, to get 5%. Others say you have to be below 30 and keep going. You have to have that much success. So is there a right way and a wrong way to frame these kind of checkpoints of whether it's working for the patient to get that next approval going? David, how do you guys do it right now? I forget.
Right now it's changing as we speak. I think it's a 6 week.
You've got 12. I'm sorry, I found it. Harvard Pilgrim has 5% weight loss at week 12.
Right, and it's all changing. When semaglutide came out, it has a longer ramp up, and our criteria didn't take that into account. So it's now, I think, 12 weeks, 5% weight loss. We did have 6 pounds at one point. So it's been a little variable. I just really can't remember.
Right. See, there's no FDA label to follow here. So that's why it's kind of interesting. Another, a major national that's publicly available says that you cannot get approved if your BMI has dropped below 25. So you have to have had 5% weight loss, but if you've gotten below 25, you can't keep getting the treatment. So clinical experts, your quick, oh, sorry, Alyssa, please go first. And then if the clinical experts have any specific guidance on what's a fair way to frame these kind of renewal criteria, I'd love to hear it. Alyssa?
Yeah, I would love to hear the comments from the clinical experts on this specifically, but actually most of the reauthorization criteria you see from payers is derived from the pre-specified stopping rule within the prescribing information. So for
I'm sorry, it is there.
yeah, and so you'll see a lot of payers mirror that. Semaglutide was interesting because it doesn't have one in the prescribing information, whereas the others do. So we see a whole spectrum of approaches there. And David brought up an interesting point that the titration period is so long that we've seen a lot of payers just kind of mirroring what they did for liraglutide, but really that doesn't give the patient much time at all or any on the therapeutic dose or the target therapeutic dose. And so just wanted to mention that I think a lot of payers are deriving their criteria from that. I'd love to hear what the clinical experts have to say regarding, those rules in the prescribing information.
All right, let's hear that. And then David, I'll come to you for your next comment or question. Lee or Scott, go ahead.
The early response or stopping rules are very helpful now. And they're based on good modeling from the clinical trials. I think this is particularly important if we continue to see, I think there's been a slow shift, but if we continue to see a shift from expert prescribers to primary care prescribers. What you don't want to see is lots of people being put on these medications, and while they're extremely helpful for some, for those that it's not helpful for, we don't want to keep taking that medication. We don't want that, risk exposure when you're not getting a benefit in any area of medicine. And so having some rule of thumb like that, and I think it is more important to look at it as a rule of thumb rather than a hard rule. But I think that rule of thumb is very valuable to have. As with all these other sort of lines in the sand that we've been talking about, while, making policy, you have to have some hard rules there. It's important that there are some ways of opting out as appropriate clinically. There are some people that don't lose, say, the 5% in 12 weeks, but that are getting a big benefit from the medication. And they should be allowed on a case-by-case basis to continue, and vice versa. Plenty of people lose 5% and are getting little to no benefit from the medication and may not be worth continuing. But, that's something that, of course, is difficult, to state as a policy, but there needs to be some wiggle room there.
Okay, maybe I will go to David next, just to try to make sure I stay on time. Go ahead.
Quick clarification, we changed ours to 16 weeks and 5% loss of BMI.
Got it. Okay, so there will, I think bottom line is that we are likely to see a lot of variability across plans in this because it's a bit of a work of art. But, there are, as you said, there are sometimes dosing algorithms in the trials. And your other point about, for every decision, for every policy, there's an exception process. And the trick here is to try to create an exception process that is flexible enough, but also fair and consistent enough. And that's always a challenge. The last thing I wanted to do before I actually give you guys another chance to give a comment, I think I have two general recommendations, one for the manufacturer and one for payers, just to get any quick reaction to. The manufacturer one would be that we want to improve access to these treatments, right? In general, we want more patients who could benefit to receive access, and that pricing will become, and already is, a barrier to access. And that obviously, according to our view of the world, that there's a way to align that price with the added benefit to patients, but that there is a cumulative kind of budget impact perspective here that we think that the manufacturers could be more aware of, and to help advance access and equity by pricing these drugs more reasonably. That's going to be kind of one thing to say. And maybe it's more narrow, but on the payer side, I foresee the possibility, it wouldn't be on purpose, but patients who switch health plans, which we know in the US system happens a lot. So let's say you're on this treatment and you've gone from a BMI of 35 to 28, and now you're switching to a new health plan, if they plop that same prior authorization criteria in front of the doctor and they say, is the BMI above 30, the patient won't qualify. So there has to be a really good process for making sure that patients switching health plans who are successfully being treated, but who no longer meet that initial authorization criteria, don't have to run through hoops and lose their prescription for months or that kind of thing. David, you know what I'm talking about. We used to call it grandfathering before, we learned that that was not an appropriate term, but it's that idea of how to make sure that patients can maintain their prescriptions.
Yeah, and we usually try to address that in our criteria. And usually it's just part of our renewal criteria if you're on it.
Right. Unfortunately, as you know, not all payers do it as smoothly as you guys do. So I think we can help highlight that as a risk. Okay. I really, really appreciate this conversation. And I apologize again that it seems like we could be spending more time. I didn't even decide that we really had time to talk that much about future research. We do have some ideas based largely on conversations with you guys beforehand on some of the ideas of where that could go. We'll talk a little bit about, the cardiovascular outcomes and how relevant or pertinent they will be for all future treatments. But in general, you've given us a lot of great insights here. And what I'd like to suggest is that you each have a chance for a final statement. And we like to ask, if you can, to make it just one sentence. And you might think of either the key theme that you really want to have hammered home that's already been said, perhaps even by you, but you want to say it again, and it's the real take-home point you want people to know. Or I also would invite you to consider making a request. Like if you said, if only payers would do X, the world would be a better place. Or if only manufacturers did Y, we would get better affordability and innovation balance. And so feel free to make that kind of request of any stakeholder, whether they're here at the table or not. I always say that you can, commas are welcome. The judicious use of one semicolon is allowed. Haiku poetry is also always a winner. So if you can, I'm going to let the patients have the last word. And I'm going to start with the payers on our way to this final round. And then the CEPAC members themselves who've been listening and participating this morning will have their chance for a final comment. So David, can I start with you for a final thought?
I think the bringing up the health equity and considering making sure we all think of obesity as a disease, not a lifestyle choice.
Good. Got it. Thank you. Alyssa?
I just wanted to say I really appreciated the perspectives of the patient advocates and the clinical experts on the panel in the meeting today, because it really does help in assessing the feasibility and the appropriateness of payer criteria. I think sometimes it's easy to lose sight of. So I think it's extremely valuable for ICER, especially to be able to relay these perspectives in their ultimate policy recommendations.
I couldn't agree more. Thank you very much. Okay, Lee.
I think that what I would say is that if obesity is a disease, which I certainly believe that it is, and I think most people here do, then we need disease and disease effect based criteria rather than anthropometric criteria for determining who needs the most expensive and the most invasive and the most effective therapies.
Lee, can I actually offer a friendly amendment? I think by disease-based, you imply risk-based, right? Kind of like they do for cardiovascular. You're suggesting that there should be a way to use other elements to decide when the risk merits.
Right. That I consider those risks clinical, because what it still is, right, it's giving you those risks predict clinically important outcomes. That's what we need.
All right. Thank you very much. Appreciate it. Scott. Oops, you're on mute. Sorry. We lost the first part of your sentence.
Yeah, sorry about that. If we all only contextualized obesity by replacing obesity with diabetes as we think about it in our heads, So whether for coverage decisions, whether for clinical decision-making, counseling with patients, et cetera, thinking about people. If we think about it in the context of its analogy with diabetes of which is also a behavior-related chronic disease, I think we get a lot closer to thoughtful decisions. Again, whether they're policy decisions, coverage decisions, clinical decisions, it helps to, take all of our ingrained bias out of the equation a little bit and contextualize it better.
Thanks very much. Okay, patients rounding into the home stretch. Joe, you mind going next?
Sure. I think I'd say it's time to give those of us that live with obesity access to this care, and that's going to take clinicians to learn the space and actually learn how to care for people with obesity. It's going to take insurers to put forward reasonable coverage of these products, and it's going to take the manufacturers building those assistance programs that we talked about earlier.
Got it. Okay, thanks. All right, Nikki.
All right. I had a little time to write something down. So two thoughts really quickly. If providers would accept that obesity is a disease and start treating it as such, things would get better. And then if payers would accept that treating obesity can save money and not just cost money, things would get better.
All right, thank you. You guys have been spectacularly insightful and helpful, and your spirit of learning and sharing your own experiences with us has been so welcomed throughout, again, the 8 months for many of you, but also just to come here and to be able to wrestle with this. We're at kind of in early days of a really interesting phase of innovation and of new, opportunities for clinical care. And you guys have really helped chart a way forward. So I do hope that our final report in incorporating some of this conversation can be useful to you and your work. And I know we'll be looking at, ICER will be looking at these issues going forward as well as we go forward. So thank you. I hope you can stay with us, but please accept my appreciation for your contributions. If you can stay, if you can't, understood. I'd like to now turn it back over to the chair of the New England CEPAC, Jason, for him to allow the CEPAC members to have their final statements as well.
Steve, thank you so much, and thank you all so much for a wonderful policy roundtable. Let me just pull up the list. All right, so I guess once again we will just go by alphabetical order. Rob, are you on? You want to start?
I am. Thanks, Jason. And thank you all for such a informative meeting. I think in my final comment, I'd like to just push back a little bit on the notion that at a population level, this is an affordable approach to managing obesity. And this is not saying that this is not a very serious issue, nor a serious medical condition that should be treated as a disease. The problem is with $4 trillion annual in healthcare expenditures right now, treating just a fraction of those with this problem through the current agents is frankly unaffordable. And if we look at the uptake of statins, for example, 30% of Americans, as estimated by the CDC, take statins. So I would just say this is something that's really going to cause a lot of thought about how we approach managing this disease.
Thanks so much. Austin?
Yeah, pretty much following on what Rob said, the size of the market, acknowledging that not everyone with obesity would use the agents that we've been discussing today. The size of the market is relevant. It's relevant to pricing, it's relevant to access, and it's actually influenced. It both influences access and is a consequence of it. So it's relevant to the conversation and the thinking around affordability at a societal level. And that did inform my thinking today. I think that's appropriate. And I'll just leave it at that.
Martha.
So I really want to load on to what Rob and Austin have just said. I agree with that, but I'm going to say something different in addition. One of the things that I'm left feeling is that this analysis has not done justice to the sort of social impact of obesity. And so that on one hand, I'm sort of driven to think that these drugs can be much more important than they're being given credit for. On the other hand, I also feel like we don't know enough about the cardiovascular outcomes. So I'm sort of left in the middle with this, but I really do think that the sort of stigma and the social limitations that happen for people with obesity is a really important piece that may have been underestimated in all of this.
Megan.
Thank you, everybody, for a great meeting. I want to offer what I think is a contrasting view to the first two comments about kind of concern about the large numbers of people and the impact of having so many of them take this drug. I mean, I think that by that standard, most drugs for common diseases would be kind of disincentivized, and that unless I'm misunderstanding it, that doesn't seem right to me. I think for this analysis, I was troubled by the long-term value for money analysis. There's often a lot of kind of questions in there, and I think there were especially large number today. And I think if we were nice in the UK, then and making the decision whether to cover it, that would lead to negotiations with the manufacturers about cost. But here it could be an incentive for payers just not to cover these drugs. And from a patient perspective, I think having effective treatments and incentivizing development of new treatments is critically important.
Thank you so much, Rebecca.
Thank you very much for today. I'll just add, in the context of people's lived experiences, I particularly always appreciate that aspect of this, and ICER's thoughtful consideration in the analysis and our voting to bring that social impact in, at least in part. And I think today's discussion, more than most that I've been involved in as a CEPAC member, reinforced the importance of those other considerations and the thoughtful dialogue. So I look forward to a few years from now coming back and looking at the longer term evidence that we don't yet have to see that impact on people's quality of lives, social impact, in addition to the medical impact. Thank you for today.
Yeah, I think we all look forward to those data coming in the years ahead for sure. Steve Kogan.
So many great comments already. I'll extend my appreciation to the experts, and in particular, Ms. Massey. Your insights were really enlightening. Thank you so much. I have to admit, when I read the report, and even sort of throughout today, I've been grappling with all of the other sort of important aspects of this topic beyond medication use. For example, food insecurity, access to nutritious foods, mental illness as a cause of and outcome of obesity, or increasingly sedentary lifestyles, the list goes on, right? So maybe conceptualizing obesity as a disease will help bring more attention to and resources to non-pharmacologic interventions, which would seem to be really helpful. But the evidence today that we reviewed does seem to indicate that medications can really be a game changer for many patients, and I don't mean to diminish that. So enough said. Great job by ICER. Thanks again for a great session.
Don.
Thank you. I would like to thank everybody, especially the patient representatives and the clinical experts, for the opportunity to participate in and witness such a robust and interesting and thoughtful day-long conversation. And I want to offer, as Steve Kogut just did, a particular shout out to the Black Women's Health Imperative. I read the written comments that they filed and the ICER response to those comments. And I thought that was an especially thoughtful dialogue, but I worry that it maybe left that organization feeling like it hadn't really fully been heard because it was just sort of words on a page. I hope that all of the patient representatives leave today's meeting feeling like they had really been heard and understood, because this is such an important subject given the prevalence of this condition in our country. Thank you.
Yeah, for sure, Don. Such an important point. Tara is next.
Hi, thanks for a really interesting discussion today. I have to say I really learned a lot just about the thinking more about this disease as a medical disease. And like you said, I know it often is thought of as a cosmetic disease, but just really changing the lens on that, I think, was a really helpful discussion. And I know we've talked about education, but hope a lot of these conversations do change kind of the way payers look at this in terms of covering treatments for obesity. But more than that, I hope it gives them an incentive to really work with the manufacturer to negotiate on price, because I don't think we should be putting all of this on the payer, right? The payer can want to cover this and think it's important, but just not be feasibly able to do that. So I hope this just incentivizes them and incentivizes the manufacturer to really negotiate on this price.
Thank you. Greg.
Yeah, coming through COVID, the importance of obesity is just so apparent, right? The risk factor there. And it's exciting to have new treatments, but it's so troubling that at these costs, the number of patients who will be untreated is going to be very troubling. And I wonder, can we shift to having obesity be not just recognized as a disease, but recognized as a public health opportunity? Well, we can't do that at these prices. So I look forward to the day where obesity becomes a measure that we're all working on and becomes a public health campaign. But I fear we're not there yet.
Thank you. Lefterios.
Hi, I would like to thank the ICER for taking on this very challenging topic. This is extremely important. I just want to remind everyone how the obesity epidemic fed the COVID pandemic and how much it impacted the very high rates of mortality that we had in the US. But addressing obesity, in my mind, and after this day discussion, is a challenge for our culture as well as for the whole health system. It's not only a challenge for a specific agent that will be the magic bullet that will change this epidemic. There is stigma that needs to be addressed. That is a cultural stigma that we need to address. There is a complexity that we need to understand. We don't even have a way to measure obesity. We use a BMI, and everybody on this discussion agrees that this is a very, very biased and not a very good measure. So how can you address something that you cannot even measure? Finally, our health system is very good in episodic medicine. I can deal with people with diabetes and osteomyelitis, and I see a lot of them, but preventing them from getting there and getting to amputation requires a long-term planning, a multi-pronged approach that our health system is really inadequate, and some long-term planning throughout the health care and the life of the patients, and hopefully we'll get there. Thank you.
Thank you, Lefterios. Stephanie.
Thank you. This was a fantastic meeting. My eyes are always opened. Again, with this meeting, I really appreciate everyone's participation. So with that said, I'm glad we have more robust treatment for the disease of obesity. I think that's incredibly important. However, the cost of medications needs to increase access rather than further demarginalize those who are most in need. And Nikki, I was particularly struck by your story, and especially when you talked about the difference you experienced between your surgery for the disease of obesity and your surgery for the disease of cancer. That really helped me to think about this in a new way. And so with that in mind, I think we all are probably aware that we have a mountain of stigma to overcome. And I'm glad we're all here together working on this, going the same way, and really modeling this for the rest of our community. So that is what I have to say. Thank you.
Thank you. Jason.
Thanks so much to everybody. And I echo so much of what my colleagues have said already. I just want to make a related but different point around evidence, because I've been struck all day thinking about one of those first slides we saw, that network diagram that showed just how few head-to-head studies, just one in this analysis we had to go on compared to a whole lot of placebo trials, and certainly not unique to this class of therapies. We probably can come to take it for granted here in the United States, this paucity of evidence, but it doesn't have to be that way. And you know, the lack of the good incentives and motivations from the FDA or elsewhere to create head-to-head trials creates so many, you know, substantial challenges to not just to groups like us, but to payers and to providers and to clinicians, and try to figure out what works best and how to really deploy these tools at our disposal most effectively and most efficiently. So I just want to renew sort of a familiar refrain that, you know, even if providers aren't required to do these head-to-head studies, it would be so important to think about other ways in our health system to help generate this evidence that could inform analyses like this, and think about these complex treatment questions, even within the therapeutic realm. But thanks to everyone for really another enlightening and great day.
Thank you. Reverend Al.
Well, thank you. Thank you very much, Nikki and Joe and the clinical experts. You know, I am in total agreement with many of you around the issue of looking at obesity as a medical condition as opposed to cosmetic or a lifestyle change. And I'm reminded, as one living with diabetes, type 2 diabetes, that same myth has been perpetrated, if you will, you know, throughout, where there is an assumption that you have type 2 diabetes because you didn't take care of yourself or you didn't live a healthy life. So, you know, I am very, very pleased with this meeting today. Number one, the conversation was so robust and very, very, very eye-opening for me. And, you know, I applaud ICER just to take on this issue, and this topic, and to really delve deep. And I want to thank the policy roundtable. I truly enjoyed that conversation, especially around equity and what equity actually looks like, and how there are some challenges there, but how do we get there? So I'm very hopeful about this, and I'm hoping that a few years from now, we'll talk about these medications that will be affordable, and that, you know, can really do what they are supposed to do. So thank you.
I'll just close by acknowledging out loud that it's always so hard to fit everything I want to say into one sentence like this, no matter how long it runs on. And I'm so grateful for the comments of so many of my colleagues just now, so much of which I agree with, the points about equity, the points about the relationships of disease and society, some of the points about evidence and comparative effectiveness, and the limitations of trials comparing different combinations to each other, and the limitations of observational data and generating comparative effectiveness evidence. But I think more than anything, I'd like to reflect, I believe years ago, my first CEPAC session was the PCSK9 inhibitors, which it reminds me of this session for a number of reasons. There's tremendous scientific advancement on a very common condition, a high price to a drug, something that we really do think it works, but set at a very high price in a way that applies to a huge number of patients. And, you know, price times quantity in economics is a meaningful concept. So it does provide a unique challenge when there's such a large population, as my colleagues have referenced. And I'll just recall the history here is that with PCSK9, there were very tough prior authorization regimens imposed, and very few patients got it. And as a result, not many patients benefited from the drug. The manufacturers didn't make as much money as they probably had hoped to, in part because of this grinding friction, this grinding friction that occurs in the healthcare system when price is misaligned with value. And that grinding friction is so challenging. Obviously, I know this as a physician with the prior authorization processes, but more than anything, we've heard this very clearly today for the patients to be told, try to lose weight for 6 months before you get it. I mean, these kinds of prior authorization processes that don't really make any sense to anyone are a consequence of misalignment of price and value. And when it's applied to the broad variety of patients, it is possible for everyone to lose, right? The manufacturers of PCSK9 probably didn't make as much money as they thought they would until they dropped the price. And I think that you have the risk of this happening here. Not a lot of patients have access to this. The price is high for where one would think because of value. And that by aligning prices better with value, we may have a much smoother path for all players in this very complex healthcare system that we work in.
Thank you, Jason. I think that was it. I think it's now over to me. One of the benefits of being the chair of the New England CEPAC is you get a little bit more than that one sentence, right, Jason? That's why you did.
I'm glad to hear that, because I certainly did just take my liberties.
That's all right. And one of my prerogatives, I guess, is to take even a little bit more than that. But I get to start by thanking again, as I think you can tell, I hope, again, they're still with us, but the patient experts, clinical experts, your influence and your opening of eyes to this group, and by extension, many others, has been incredibly helpful. So just a couple of personal reflections as we round out. So like most of us involved in the healthcare arena, I have witnessed and probably been part of bias against people living with obesity, certainly years ago. But I've actually seen it operate in lots of different ways. And I found that I came out of that experience also with a bias against the treatments for obesity. When ICER first looked at treatments for obesity a few years ago, the drugs were almost an afterthought because they were so rarely used, and everybody just said, oh, fen, they're always over-marketed, overhyped, they never work. It's kind of like diet and exercise, right? It just doesn't work anyway. And we were focused on bariatric surgery, which was a newer and shinier thing at that point, and other interventions. And I will tell you one that I'll never forget. It was, and I will oversimplify it, but it was basically putting a tap into the stomach so that after a patient ate a full meal, they could offload that meal almost immediately instead of having it go through their digestive system. And the basic idea that we would do this as a society to help address our problems with obesity struck many of us as just kind of barbaric almost, right? I mean, it's like putting a tap in so you can eat as much as you want and then just offload it. It seemed like, boy, we were just over medicalizing, doing everything. And even shortly before then, I had been at Medicare for a year when bariatric surgery was first coming through. And I can tell you that a system that pays doctors on a fee-for-service basis to do things will always worry about overuse and will always find that things are overused. And so Medicare came out of that trying to be very careful with how bariatric surgery was used, because it was always going to be overdone in one way or the other. So here we are today, and it's like, this is a wonderful event to have the celebration, again, as I mentioned at the outset, of having much more effective and less harmful approaches to treat a condition that is not the fault of the people who live with it. And that's one of the key themes that we keep coming back to. But that is really, really true, that whatever we think about the treatments, the living with obesity is not the fault of the person. And we have every hope that we can contribute to that message getting out. But then again, when I come around to the costs and the broader societal implications, I have another memory of when I spent a year in England. And when I was taking my very youngest child to school, I noticed a group of mothers who had dropped off their children. And these were clearly women who were not born in the UK. By their dress, by their language, you could just tell they were immigrants. And what the National Health Service was doing was sending nurse matrons to the primary schools to work with immigrants around how to buy healthy food in a British grocery market and how to cook your food from your culture here in the UK. They were trying to get out in front of a lot of health issues and access issues. And yes, maybe they have to scale back some of their payments for some of their drugs, but that's part of the balance that they seek between prevention and treatment in a system that tries to look at the bigger picture. And I do worry that we're not good at that. We completely blew it with COVID, right? Even when we knew it was coming and when we had it, we couldn't figure out how to deal with it then. And I feel like we have to deal with this in some way with a problem like obesity. And no one knows the right answer, but we just have to keep looking at it big picture, I feel. And I worry that the easier the treatments get, the easier it might be for us to forget that. And the price has to be part of it. So again, maybe high value when you're facing a public health problem like obesity is not at the margin of incremental cost effectiveness, but it's at a margin where we save money for the health system so that we can have more money for prevention efforts in the schools or in more research around diet and activity or whatever it might be. So I feel like we're still at risk of being out of balance as much as we welcome and celebrate and want to provide good access to the newer treatments. My hope is that we can somehow take that step back, and even though we don't have a national health system, pretend that we do and keep on thinking about the people and the children that we may help if we spend some resources and time thinking about prevention from a really early standpoint in our society. So that is way more than one sentence, and it should end where it began, with the thanks to all of you participating in this meeting, the clinical experts, patient experts, the payers who came. Our regrets that the manufacturer did not participate in this kind of conversation. And New England CEPAC, thank you. You guys are fantastic. Great debate around the evidence, the values, and the recommendations that we'll take forward. So we'll be putting out a version of the final report in usually just a couple of weeks at most. Like all of our reports will go onto the ICER analytics platform where it can be found with all of our other material. And I wish you well at the end of the day. Let it be known that on September 16th, 2022, we finished an ICER meeting ahead of schedule. Have a good day, everybody.